Good morning, everyone. So we start the day 2 of the 7th Global Rhinoplasty Update 2023 with a discussion on surgical anatomy of the nose. I'm Dr. Shosri Kumar. I'm associated with the Institute of Otorhinolaryngology and Ethnic Surgery, Kolkata.
Good morning.
So yesterday, Gulati sir had discussed why the nose is important. There are a few more importances of the nose. One is the function and the aesthetics of the nose. So we all know about the functions of the nose. One is the airway, warming, humidification of air, filtration, olfaction, and resonance of voice. So what happens if we have a poor function of the nose? One is disrupted sleep, which leads to chronic fatigue, stress, depression, weight gain. Perpetual breathing problems lead to dental issues, dry mouth, poor sleep, mood fluctuations. There are constant headaches, loss of taste and smell, and all of this ultimately leads to dwindling quality of life, which strains your physical and mental well-being. The aesthetic importance is that the nose is the center of attention of your face. A large nose, a small nose, a wide nose, a crooked nose, all of it leads to a distorted perception of other features of the face. So like all the forts in Jaipur, which reminds us of all the wars fought hundreds of years back, it is the theater of all events. So we are going to learn about the theater of rhinoplasty. The topics of discussion are the skin or the soft tissue envelope, the ligaments, osteocartilaginous vault, the ala, the septum, the valves of the nose, the vascular supply, surface landmarks, angles, and measurements. Skin and soft tissue envelope. It has the epidermis, the dermis, the superficial muscular aponeurotic system, which is continuous with that of the face. It has two layers, the superficial fatty panniculus, the fibromuscular layer, then the deep fatty layer, the perichondrium or periosteum, and then comes the cartilage or bone. Now the skin or soft tissue envelope is one of the most important parts of rhinoplasty because of its high variability from the top to the bottom of the nose and its high variability in each and every patient. It is thinnest at the rhinion and thickest in the upper 1/3 of the nose where the procerus muscle is also there, and it is also thick in the supratip region. The thickness of the skin or soft tissue envelope is very important in determining the outcome of a rhinoplasty because it depends on what the size or the type of graft that we'll use, and counseling of the patient regarding the skin or soft tissue envelope regarding the expected outcome is very important. So there are many ligaments in the nose. One is the interdomal ligament, the intercrural ligament, the Pittengeist ligament, the footplate sling, the piriform ligament, the scroll ligament, and then we'll discuss about the tip support. On the left side of the screen, you can see the interdomal ligament. It connects the two middle cruces and is positioned posteriorly and cephalically to the dome. Then on the right side is the intercrural ligaments. It connects the cephalic border of all the parts of the lower lateral cartilage and it acts as a suspension ligament because it is placed anterior to the anterior septal angle. The Pittengeist ligament. In 1965, Pittengeist had described a dermocartilaginous ligament, and later in 2009, Dr. Saban and Polselli had demonstrated that the medial smax divides into two layers, a superficial and a deep layer, which goes above and below the interdomal ligament, and the deep layer attaches to the depressor septi nasalis muscle Therefore, the tip can be pulled down during contraction of the musculature. The foot plate sling. So one of the major tip supports is the attachment of the caudal septum to the foot plates of the medial crural. So this is a fusion of the superficial and deep layers of the Pittengeist ligament, which wraps around the caudal point of the septum and the columnar base. The piriform ligament is a fusion of perichondrium of the lower lateral cartilages and the frontal process and the periosteum of the frontal process of maxilla. Now the scroll ligament. The scroll ligament has two parts, the longitudinal scroll ligament and the vertical scroll ligament. The longitudinal scroll ligament attaches the cephalic border of the lower lateral cartilages to the caudal border of upper lateral cartilages. And the vertical scroll ligament attaches the deep Smas layer to the internal nasal valve area. This vertical scroll ligament is found when we are dissecting from down up from the lower lateral cartilages to the upper lateral cartilages. Now the tip support. The major tip supports are three. One is the size, shape and resilience of the lower lateral cartilages. Two is the attachment of the medial crural foot plate to the caudal septum. And three is the attachment of the cephalic margin of the lower lateral cartilages to the caudal border of the upper lateral cartilages. There are many other minor supports: the dorsal septum, interdomal ligaments, membranous septum, anterior nasal spine, the attachment of the lower lateral cartilage to the skin soft tissue, the lateral crural attachment to the piriform aperture. The osteocartilaginous vault consists of the nasal bones, the frontonasal process of maxilla, the anterior septum, and the upper lateral cartilages. So the attachment of the nasal bones to the frontal bone is the nasofrontal suture line. The attachment of the nasal bones to the maxilla is the nasomaxillary suture line. The nasion and the celion. So before discussing the nasion and celion, we have to know what the radix is. The radix is an area. So if a line is drawn from the nasion, which is the deepest bony point of the radix, to a line at the level of the lateral canthus, and the same area above is the radix. So the deepest bony point of the radix is the nasion, and the deepest soft tissue point of the radix is the celion. The K point is the meeting point of the nasal bones, the anterior septum, and the upper lateral cartilages. The separation point is where the upper lateral cartilages separate from the septum but are still attached with perichondrium. The caudal point is the caudal-most point of the upper lateral cartilages on the dorsum. The scroll point is the angle between the caudal border and the lateral border of the upper lateral cartilages. And the junction point is at the meeting point of the nasal bone, upper lateral cartilage, and the frontal process of maxilla. And the upper lateral cartilages extend deep to the nasal bones, and the extent of the upper lateral cartilages deep to the nasal bones is variable in every patient. The alar cartilages are divided into three parts: the lateral crus, the middle crus, and the medial crus. The lateral crus is the largest, and then the middle crus is divided into the donal segment and the lobular segment. And the medial crus is divided into columellar segment and the foot plate segment. But the alar has a very important part, that is the atella subcutanea cutis. Dense fibrotic tissues with multiple fibrotic septi connects the dermis to the underlying musculature and forms the nostril sill and the alar lobules. So this part is independent of any cartilage or bone, and any problem in these areas need to be addressed separately. The septum. So it has a membranous septum, cartilaginous septum, and a bony septum. Cartilaginous septum is formed by the quadrangular cartilage, the bony septum by the ethmoidal plate, vomer, the crest of the maxilla, and other minor contributions from the crest of the palatine bone, the crest of the nasal bone, the spine of frontal bone, the spine of anterior nasal spine of maxilla, and the rostrum of sphenoid. There are three valves in the nose. One is the external nasal valve, the vestibular valve, and the internal nasal valve. So this is the external nasal valve, which is medially bound by the medial crus, laterally by the lateral crus and the fibrous part of the ala, and inferiorly by the nostril sill and the floor of the nasal cavity. This is the vestibular valve. Medially it has the cartilaginous septum, laterally the lateral crus of the lower lateral cartilage, accessory cartilages, piriform ligament, and inferiorly the floor of the nasal cavity. This is the internal nasal valve, medially bound by the cartilaginous septum, laterally the upper lateral cartilage, piriform ligament, inferiorly the floor of the nasal cavity. And the internal nasal valve area is posteriorly bound by the inferior turbinate. The angle formed between the upper lateral cartilage and the cartilaginous septum is called the internal valve angle, and this is 10 to 15 degrees. So the spreader graft is often used in this angle to increase the size of the internal nasal valve. The vascular supply is from the external carotid artery and the internal carotid artery. The facial artery and the dorsal nasal artery, which is a continuation of the ophthalmic artery. The facial artery gives the superior labial artery, the angular artery, which gives further branches into subnasal artery, columnar artery, marginal artery. And the dorsal nasal artery comes and meets all these branches and forms an arterial arcade called the alar arcade. So some of the surface landmarks are from the top. The trichion is the lowermost point of the hairline. Then the glabella is the most prominent point on the forehead. The nasion, as has already been discussed. The rhinion is the soft tissue point of the osteocartilaginous junction. Then the supratip is a point just above the tip. Then the tip, the subnasal, the labral superius, stomion, and menton. So the menton is the inferior-most point of the chin. The anterior-most point of the chin is the pogonion, and the nathion is a point of intersection between a line drawn from the cervical point to the menton and from the subnasal to the pogonion. Now, angles and measurements. The face is divided into 3 parts horizontally and 5 parts vertically. So the horizontal division is made from the trichion to glabella, glabella to subnasal, and from subnasal to menton. And vertically, it is divided to the lateralmost point of the pinna, to the lateral canthus, from lateral canthus to the medial canthus, and similarly on the other side. Now, all of these parts need to be same or proportional to each other. On your left side, you can see one of the most important planes, that is called the Frankfurt's plane, from the superior-most point of the external auditory canal to the inferior-most point of the infraorbital rim. Often during taking pictures, this plane should be horizontal, and a lot of other lines are calculated in respect to this line, either parallel to it or perpendicular to it. The nasofrontal angle. It is formed by 2 lines. One is from the nasion to the tip defining points, and another from the nasion to the glabella. This angle should be 120 to 130 degrees. On your left side is the nasofacial angle, a line drawn from the glabella to the pogonion and one from the nasion to the tip defining points. This angle should be 30 to 40 degrees, ideally. On your right side is the nasomental angle, a line drawn from the nasion to the tip defining point and the tip defining point to the pogonion This should be 120 to 130 degrees ideally. On your left side is another important angle, is the nasolabial angle. This angle is from the subnasal to a tangent drawn along the columella and from the subnasal to the labial superius. This angle should be 95 to 105 degrees, more acute in males and more obtuse in females. And on the right side is the nasal projection. If a line is drawn along the alar crease perpendicular to the Frankfurt's plane discussed before, and another line drawn from the tip defining point to the alar line perpendicular to the alar line, this is the nasal projection. And according to the Goods rule or Goods method, nasal projection should be 0.55 or 0.66, that is 60% of the nasal length, which is the length from the nasion to the tip defining points. Now all these pictures and most of the study material has been taken from the Atlas of Rhinoplasty by Dr. Roland Daniel and the Rhinoplasty Dissection Manual by Dr. Dean Toriomi. I would like to thank everyone for listening to me and thank Dr. Sunil Talwar for giving me the stage such early in my career. Thank you, sir.
Thank you, Dr. Swastik Kumar, for nice presentation about surgical anatomy of nose. Now, our next participant is Dr. Vishal Mohan. He is consultant at Akash Center for Rhinoplasty Center.
Nice presentation, man. I'm Dr. Kapil. I just, for benefit of delegates, I want to just know that so many lines and so many angles are there. And I know for last 20 years I'm doing the rhinoplasty. How many angles you know in your practice are important for them, because everything cannot be measured. So what are the angles of importance in rhinoplasty which has to be measured? So just tell them that they will not be confused actually by having so many lines in them.
One is the tip rotation and one is tip projection. These are one of the most important features which we need to keep in mind while doing rhinoplasties. So one of these things is determined by the nasolabial angle. The nasolabial angle is drawn from the subnasal, a tangent is drawn along the columella, and from the subnasal to the labial superius. So this angle is easily measured by photography, and it is often seen that a patient has a droopy nose or an over-rotated nose or a derotated nose. So this angle can actually change the look of the patient by just changing this angle. So one is this angle. Another is the nasofrontal angle, which besides the height of the radix, it can be a shallow radix, it can be a high radix, it can be a shallow radix or a deep radix. So nasofrontal angle is from the nasion to the tip defining point and from the nasion to the glabella. This should be 120 to 130 degrees, because this angle can make the nose look short or long. If it is very shallow, it can make the nose look very long. Or if it is very deep, it can make the nose look very small. And another point that I have missed in my slide is the columellar show. It is the height of the columella if measured from the alar nostrils. It should be ideally 3 to 4 millimeters. So these are few of the important. If I have missed anything, sir.
Nothing. You have not missed, but just very simplified way.